I think that's worked. Okay, perfect. So I'd just like to begin today by acknowledging the Whadjuk Noongar people, who are the traditional custodians of the lands on which we meet today. And I'll pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander people here today. So look, I'd like to really thank Professor Grant Waterer, who I'll introduce more fully in a minute, for giving this talk. I asked Grant to present on COVID-19 in a way specifically designed for medical students, because I think the fact of the matter is that as medical students, you're really the surrogate doctors within your families and within your friend groups, and I'm sure you're constantly being asked questions about COVID-19. On top of that, as soon to be frontline workers, you also want to fully understand COVID-19, not just for the care of your own patients, but also for your own safety and the safety of your loved ones. So the way this will work is that Professor Waterer is going to present for around 30 minutes or so. It's very open. And then there'll be ample time for, after his talk, for people to ask whatever questions they would like. Please enter questions on the chat line. And that's very annoying, that transcript. Hang on. Please enter questions on the chat line, and then I'll try to ask or answer all the questions. And hopefully Stu or Matt are around your year reps. They can help to ask any questions that are highlighted that I may have missed. So I don't want to delay any further, and I'm very pleased to introduce everyone to Professor Grant Waterer, who's a respiratory physician and Professor of Medicine at the University of Western Australia, and the Director of Clinical Services at Royal Perth Hospital, and he gives a lot of the COVID updates on a monthly basis to the hospital group. He's an expert in acute lung infections and a member of the American Thoracic Society. So Grant, I'll hand over to you. Thank you very much.
Thanks, Neil. Let's see if I can do this. Okay, I hope, Neil, you can see those slides?
Yes, I can. Thank you.
Okay. All right. Well, thanks, everybody. I'm just going to run through hopefully what I think is useful information for you to have, and then obviously leave plenty of time for questions. First, I think it is actually really important to understand SARS-CoV-2 is to understand a little bit about the pathophysiology of SARS-CoV-2. Now, it's a relatively simple RNA virus, and the key thing is, as many of you will know, that the spike protein, which is the protein that it uses to attach to cells and inject its material into cells, uses the angiotensin II converting enzyme receptor. That is its primary target. There are a few other little other receptors around the body which are similar, but this is the primary target. Now, not all coronaviruses use that target. For example, MERS, Middle East Respiratory Syndrome virus, doesn't. But SARS-CoV-2 and SARS-CoV-1 both use the angiotensin II converting enzyme receptor. That's relevant because the big sites of this receptor are in the lung, epithelium, in the endothelium and in the endothelium of blood vessels. There's also a reasonable amount in the gut, and that in terms of particularly the small bowel, and that becomes relevant in a little bit. But a virus that's going to primarily attack the lung, epithelium, and blood vessels is going to give a pretty, you can kind of guess what's going to happen. Patients who get severe COVID-19, and I'm talking here now about, the full syndrome in unvaccinated patients. There is a group of patients who die relatively early in the first 7 to 10 days. And they have an overwhelming virus infection of the lung. And when you cut the lung open, it's teeming with virus, and there's some immune response, but the primary problem is the lungs overwhelmed with virus. And that's only about 5% to 10% of deaths. The vast majority of people who end up in ICU have a very typical phenomenon where they a little unwell for 7 to 10 days, and then during that 7 to 10 day period, they suddenly become much worse over 24 to 48 hours. And that's associated with high blood levels of cytokine. You might have read about cytokine storm. But essentially what happens is an immune-mediated damage to the lung. And when you cut the lung open, you don't see virus. In fact, the virus is almost absent. But what you see is a lot of inflammatory cells with neutrophils and macrophages that are causing the damage. And so the majority of damage, the majority of people who die from severe COVID are actually dying from immune-mediated damage to the lung, obviously in response to the virus, but it isn't actually the virus itself that's still causing the problem. And then the third problem, which overlaps with both of these, is the widespread damage to blood vessels means that you get clot almost everywhere. And this is a real problem. And this is visually perhaps the best demonstration I can show you. On the left here are normal lungs, and you can see all these little tiny red blood vessels are the normal small vessels of the lung. And this is by dual energy CT scanning, which is something we can do at all of our tertiary hospitals. But here you see in severe COVID-19, and you can see how pruned, how drastically reduced all these blood vessels, small blood vessels are. And it's not only the small blood vessels of the lung, but deep vein thrombosis, pulmonary embolism, stroke, myocardial infarction, and clots almost everywhere. Superior vena cava, aorta. Clotting is a huge problem, and that's one because the virus is directly binding to the endothelium and causing inflammation. But in actual fact, COVID-19 also directly activates the coagulation system, and that makes some of our normal anticoagulant measures less effective because it kind of bypasses that. So just keeping that pathology in mind of attacking the lung, obviously initially the sinuses because that's where you breathe it in, and the upper airways, the lower airways, the blood vessels. Keep that in mind as we now think about the epidemiology. So normally when you have a pandemic, a new virus typically will come out of season. And it will just, much like we did with swine flu in 2009 or SARS, or if you go back, usually there's a huge peak initially. And then in your first winter, you get another big peak where it's the dominant virus that winter. And then in the second winter, a little less, and then in the third winter, and then it just goes into the background. And even today, 12, 13 years later, the swine flu strain of 2009 is still the leading strain of influenza every second or third winter. And so this is what we would normally expect to see. And so if you think about that for a moment, and I'll talk about strains other than Omicron in a second, but what we would expect to see in actual fact is this peak of Omicron that we're having, probably another peak later in winter, and then next year and the following year. And so the reality is that despite all the vaccines, even if we get incredibly lucky and Omicron's the last variant, we're stuck with COVID for at least the next 3 to 4 years as being a dominant player, certainly in the winter. So COVID's not going away, and all of you are going to be, even the first years, I suspect, are going to be doctors in a COVID, if not pandemic, at least winter epidemic setting. And the problem, of course, is mutants. And viruses mutate regularly. That's what they do. That is their primary survival and adaptation mechanism. They're designed to break and reform. Their RNA and their DNA is relatively unstable, particularly the RNA viruses like coronavirus. And so every time a virus replicates, there is a chance of a mutation. Most of those mutations are garbage, but every now and then one arises that is more challenging. And at the moment, and if you look at, Perth hasn't even started to factor on this world radar yet from yesterday. There's a tiny, tiny little red dot. But there is more COVID or more SARS-CoV-2 virus replicating at the moment than any other virus in the history of mankind. So, and probably of the world. So we're going to see a lot of mutations. And, initially, this is a marathon. And initially, the normal variant came along, and then lots of other variants jogging for position. And Delta had its time at the front. It was more infective and, in fact, just as lethal as Alpha. Omicron is now the leader of the pack, but it's very unlikely that Omicron's the last variant we're going to see. Every time a virus mutates, it's random as to whether it's more infective, as to whether it's more able to escape the antibodies that we produce from natural immunity or infection. And it's also random generally in terms of whether it's more or less virulent. So there's no reason that viruses would want to mutate to become more virulent and kill more hosts. That's a purely random toss of a coin. But we will absolutely see competition for variants that are more infective, and particularly those that can escape natural immunity or vaccination, right? And that's what obviously influenza does, but there's an awful lot more COVID floating around at the moment than influenza. So what's next? There will be something relatively soon. There is a biological limit to infectivity. So most of you will have heard of R naught, which is a measure of how much a virus will spread. So an R naught of 2 means that on average, each person will infect 2 other people. And so if you want to break the chain of transmission, you've got to vaccinate a bit more than 50% of the population so that each person on average infects a bit less than 1 person, right? So if you vaccinate 50, if the R naught's 2 and you're going to infect 2 people, if you vaccinate one of them, that's down to 1. So if you vaccinate slightly more than 1, on average, the virus will die out over time. The original strain of COVID had an R naught of about 2.5. Delta was around 5 to 8. Omicron looks like it's around 8 to 10. The most infective virus we know is measles, which in some settings has an R naught of up to 18. So there's still scope for COVID to become much more effective. However, we're also now going to see immunity from prior infection and vaccination kick in. So what we're really going to favour is mutations that are either more effective or particularly those that are going to escape acquired or vaccine-induced immunity. Just for a moment to pause and give you some perspective, because everyone, says, well, COVID, disaster, worst pandemic known to mankind. You've got to have a bit of historical perspective here. So there's been 2 outbreaks well documented of hemorrhagic fever, meaning Ebola essentially in the world. This was the most damaging. So in Mexico, and basically we're talking about Central America here, prior to the arrival of the Spanish, a population of around 22 million, and when the Spaniards brought in smallpox, that dropped. But then there was an epidemic of coccolizzi, which is a hemorrhagic virus that basically in 2 peaks wiped out 90% of the population of Central America. And that is what viruses can do. The other big pandemic was the pandemic of St. Cyprian in the Roman Empire in about 247 AD. And that wiped out 25% of the known Roman world and was a major factor in the collapse of the Roman Empire. So, if you put this into perspective, yes, there's a massive amount of economic damage, but the overall mortality of COVID is probably going to end up being 0.1% of the population or less compared to viruses that have outbreak. So there is enormous potential for viruses to be civilization-ending events. We have, in some respects, got lucky with this one. Moving on to COVID-19 and especially Omicron, how do they present? So in triple vaccinated people, what we know is that more than 50% of people will actually be asymptomatic when they have COVID, no symptoms at all. The typical symptoms that you do get, and this applies to both symptomatic, both vaccinated and unvaccinated people, is initially an upper airways infection, like a typical cold, sore throat, stuffy nose, sore ears. And that's, of course, because that's where the ACE2 receptors are, and you're inhaling COVID as your initial, or touching a fomite and getting on your face, and it's that area that gets infected first. And our vaccinations are great at producing antibody levels in the blood, and why that's important I'll get to in a sec. But our vaccines are not great at producing IgE in the sinuses or in the lung or in the gut. And so that's why people who are vaccinated do still tend to get symptoms in those areas. Loss of smell, the anosmia, was very common with the original strain of COVID, up to 3/4 of patients. Certainly with Omicron, it's like less than a third, and it's not a particularly useful symptom anymore. However, if you do get sore throat and anosmia, odds on it's COVID. There is gastrointestinal spillover, and that's, again, because you're swallowing your secretions, it's going into your gut, and your vaccine immunity is not, again, protecting the gut as well as it does the blood. And so nausea, vomiting, diarrhea, abdominal pain are very common symptoms with COVID-19. And so one of the things that I will tell you, and I'm sure I'll put this again later in the slides, is you want to make sure you've got some Gastrolite at home or some other kind of fluid replacement, because it is fluid depletion that is the main reason that vaccinated people tend to need to come to hospital, not so much respiratory distress. With the local infection, you do get some systemic inflammatory response, so a bit of fever, headache, bit of muscle ache, bit of lethargy, just like any bad kind of head cold you can get. Moving on to more severe symptoms, it's not uncommon to get a chest pain that's not a typical ischemic heart disease type crushing central pain, weight-like. It's more often described as kind of a dull, persistent ache. It may be a bit positional. I mean, that's due to myopericarditis, and most of that is all subclinical, normal ECGs. But in a group of people, you do get some ECG changes. A severe headache and even meningism, so meaning some photophobia, some neck stiffness, is also a common presentation, particularly with Omicron. And that can be a reason for people to present to ED, but it virtually never goes on to a proper viral meningitis demonstrating virus in the CSF. And most patients, if they're COVID positive, there's no need to do a lumbar puncture or anything like that. Now, everything is in red here because these are disease processes that are pretty much stopped by vaccination, even in a lot of people who have an impaired vaccine response. They have enough antibody in their blood to sop up the virus so that it doesn't cause the widespread endotheliitis. And it does also appear that the immune-driven lung disease is not actually as a result of virus tracking its way down the respiratory tract. You actually require the viremia to dysregulate the immune system such that you get this diffuse alveolar damage. So with the systemic viremia, you get the endotheliitis and the coagulation. So one of the key things in COVID is the person vaccinated or not? Because if they're not vaccinated, then almost everything is possible in terms of there being clots. The pneumonitis, the involvement of the lungs is primarily also associated with the systemic viremia. And then, of course, the immune deregulation I talked about, the cytokine storm, the acute respiratory distress syndrome and diffuse alveolar damage, again, is generally very well protected for by anyone who's vaccinated, although it still can rarely occur. And as I've said several times, clot almost anywhere and everywhere. And it's really important in an unvaccinated person to not discount weird symptoms. So, weird leg pain, foot pain, abdominal pain, all could represent things like clot to a subclavian artery or a femoral artery or a popliteal artery or a splanchnic vein. And you need to be very, very careful of thrombosis. And that's why anticoagulation is key in these patients. As I said, Omicron's more infective than Delta, so it's rapidly overpacing it. There's no question it causes less severe disease, especially in the elderly. And whereas Delta and prior variants, it was predominantly a respiratory infection and a respiratory decline. with more than 85% of patients being admitted for respiratory reasons. With Omicron, it's more 50-50, and a lot of people being admitted with abdominal pain, vomiting, diarrhea, dehydration. However, in the ICUs, it is respiratory failure that's still driving ICU use. In terms of treatment, personal protective equipment, PPE, PPE, PPE. Got to know your PPE, got to know how to use it, got to know what fits you, got to have someone checking you to make sure that it's being used properly. Now, unlike early in the pandemic where we had no vaccines, no treatments, not that we still have any real effective treatments, PPE was absolutely critical to stop you from being exposed. Now, the main reason for PPE, frankly, is to make sure you don't get a very large viral load when you're initially infected, because the bigger you're infecting viral load, the more severe disease you're likely to have, because essentially the virus infection is a race between the virus replicating in your immune system. And what vaccination does is give your immune system a head start. But if you have too much virus to start with, then you put the virus at an advantage. 50% of us, and frankly, in the young, like most of you are, probably 70 to 80% are going to get infected with COVID in the next 18 months, shopping, going to a movie, going to dinner from someone in your household. That is the reality. So your protection is vaccination. The reason for the PPE is that you just don't want to have a huge dose of virus for your initial infection. Oxygen is a mainstay as people need it, and we tend to use high flow nasal oxygen, there are newer machines that we can give reasonably high levels of oxygen and also give some positive end expiratory pressure, which helps keep the alveoli in your lung open a bit better. And it's been shown that that approach avoids some people going on to need mechanical ventilation. If you're hypoxic, we give steroids, and the dose is 6 milligrams per day for 5 to 7 days. And that has problems. Steroids tend to make elderly people in particular much more confused and delirious, and it puts your blood sugars up, and that is a problem because high blood sugars are also associated with a lot of complications. I don't want to confuse you with all the data, but there's also quite a bit of data that steroids really aren't very effective in the over 70s, and they're not effective in people who've had less than 7 days of symptoms. So they are of some benefit in some patients, but overall, certainly not a magic therapy. Venous thromboembolism prophylaxis and therapy, if patients are admitted. So some form of full strength low molecular heparin is generally recommended in anyone who's admitted unless there's a contraindication because of the vast amount of clotting. Early antibiotics, at least in the first 48 hours, because depending on the study you look at, anywhere between 8 and 20% of patients will also have a bacterial pathogen present if they have evidence of pneumonia. But now that we've vastly uplifted our microbiological testing capacity, and one of the great things about COVID is stuff that has been played around with for 20 years and not been able to find a niche in hospitals, all of a sudden every hospital in the world has acquired, and we've had a massive uplift in our ability to look for and find pathogens quickly. And so, if after 48 hours all you've found is COVID, you can absolutely stop antibiotics. It's important to watch the troponin, which is a measure of cardiac damage, and the D-dimer, which is a measure of clotting, as they give you important indications about prognosis and what damage might be going on. As I've said, personal protective equipment, personal protective equipment, personal protective equipment. It works. One of the intensive care units where I work occasionally at Northwestern in Chicago, they've looked after more than 2,000 patients with COVID. They do bronchoscopies on all of them. They had not a single healthcare worker require infection in their ICU, and they don't use fancy suits connected to air machines. They just wear an ordinary N95 mask and goggles. Electrolytes and fluid balance are important because of the dehydration. As I've already said, the blood sugar level is a problem. There are drugs which block interleukin-6 in one way or another that tend to be indicated if you're already on oxygen and your oxygen needs increase. We tend to use those, although they, again, are not magic. And And then there's all sorts of ways that we can assist ventilation if necessary with positive airflow, mechanical ventilation, or even extracorporeal membranous oxygenation. So that's a machine basically that acts as an artificial a lung for you. And managing delirium is a real problem because a lot of the patients who are admitted are elderly. They're delirious because of COVID, they're delirious because they've destabilised their ordinary medical problems, and they're delirious because we've given them steroids. One of the obvious questions is there anything we can do for people before they get sick? There are a bunch of drugs which are basically monoclonal antibodies directed against the spike protein. And these were developed early in disease with the idea that, well, if the virus with its spike protein is wandering around trying to stick on your blood vessels and that's the problem, let's have something like an artificial antibody that comes along and sucks them up. What we have available is sotrovimab. There's a very small benefit to it in non-vaccinated patients. It's incredibly high cost. There's no data at all in vaccinated patients as to whether this works. But it possibly has some utility in the highest risk outpatients, so people who are heavily immunocompromised. And you need to give it within 3 to 4 days of symptoms. So there is a state program for being able to give this, but it's very, very limited to the people. And it's basically, people have had heart and lung transplants or are on very heavy immunosuppression for one reason or another, renal transplants, for example. We do have some antivirals. Remdesivir is the one that came out first because it was in trials for Ebola. It really is a very, very poor antiviral. It has minimal effect on hospitalisation and no effect on mortality. It might reduce symptom duration, but it's basically progressively fallen out of favour. Molnupiravir is a new one. It is a drug that is designed to disrupt viral RNA replication. For that reason, it's teratogenetic, so you don't want to take it if you're young. It has no effect on people once they're hospitalised. And the trial also had no effect on people who had antibodies. So anybody who had a prior infection or been vaccinated, it had no effect. Its other problem is you've got to take 10 really large tablets. Now, they are rolling this out to the nursing homes, but all the nursing homes are finding that no one will take it because of these 10 large tablets. And to be honest, it doesn't have a great efficacy anyway. Nirmatrelvir, ritonavir, so this is a combination of a COVID specific antiviral and a HIV antiviral, which is there to stop the liver from metabolizing the nirmatrelvir so quickly. It has a lot of drug interactions. Again, we don't have any data on vaccinated patients, and there is a strong suspicion that its efficacy will not be very good in vaccinated people. But it is easy to take. It's probably better. There is better data in the elderly, and there are very, very limited supplies at the moment. But this will probably be, this is Paxlovid, this will probably be the main antiviral we'll use in hospitals. What do you look out for in COVID? Basically increasing oxygen requirements. Typically, as I said before, this is 5 to 9 days after the onset of symptoms. It's usually slowly progressive over 24 to 48 hours, but it can be sudden if there's a pulmonary embolus. It is, lots of people have bought pulse oximeters at home, and that's not an unreasonable investment given that you can get quite reasonable pulse oximeters at quite a cheap price now, well under $80. Anticoagulation, if not, why not, given the high amount of clotting, watching the blood glucose, watching the fluids and electrolytes. And there's rarer stuff that you just got to be on the lookout for, like myocarditis, stroke, clots in weird places, especially again in the unvaccinated. And that's why understanding if they're vaccinated or not is so important. Long COVID, there's been a lot of publicity about. One of my friends runs a clinic in Barcelona where they now have 14,000 patients on their waiting list for long COVID. And around, of people who are not admitted, around 5% to 10% will complain of symptoms of long COVID. Those who are hospitalised, about 20%, and those who go to ICU, a third to a half. And this is a mixture of, to be honest, pure psychological symptoms. And there is, for example, lots of people who have vague symptoms looking for a cause, and if you've had COVID, you will assign it to that. However, amongst that probably 50%, there are real pathologies that you can identify, either true post-traumatic stress syndrome. There is a syndrome of post-critical illness where people who've been severely unwell for a long time develop myopathies and neuropathies and cognitive impairment and sleep disturbance. And then there are probably amongst all of this up to 20% had demonstrable chronic damage to either the lung, heart, brain, or gastrointestinal tract. They all can present with a variety of symptoms. And so even after acute COVID is burnt out, we're going to have a long tail of dealing with long COVID. How safe are triple vaccinated healthcare staff? So with Delta, we know there's incredibly high protection against infection. High protection against infection, extremely high protection against hospitalisation and death. The number of deaths from Delta in triple vaccinated staff in the populations where that's been studied worldwide is in the handfuls. With Omicron, we're seeing a lot of infections in vaccinated healthcare workers, but almost no hospitalisation. The Queensland data would suggest the risk of hospitalisation with a healthcare worker is less than 1 in 10,000. And I'm still not aware of any death worldwide from a healthcare worker who's been triple vaccinated from Omicron. And I think to date, less than 5 ICU admissions, and all of those people who've had transplants. Just some of the data, this comes from Israel. And what you're looking at here is white is essentially unvaccinated. Blue is, the colour of blue indicates the recency of vaccine, so that the darker blues are more distal vaccination, so up to 6 months prior, through to more recent vaccine. And you can see in all age groups that by 6 months of vaccination, you are losing most of the protection against confirmed infection. And that was the reason for the booster being introduced, and being introduced early at around 3 to 4 months. However, in terms of hospitalisation, what you can see here is in young people, in middle-aged adults, even 6 months ago, a vaccine was still providing more than 50% protection against hospitalisation, and it was only really in the over 60s that you were losing that. In terms of how quickly a vaccine booster works, you can see here, this is your relative risk of getting confirmed infection. Within around 10 to 12 days, you're up to around 6 to 7-fold reduction in your risk. And by the time you get out to 3 weeks, you're talking a 20-fold reduction in risk. So the booster is incredibly effective. What we don't know is how long it's going to work. And you would think, from what we know of immunology and vaccine immunology, my guess would be 6 to 9 months we'll get reasonable protection, and it will decline over that period. It wouldn't surprise me if we see recommendations to get another booster, which by then will probably be one of the newly formulated vaccines for Delta and Omicron, around 6 to 9 months after the previous booster. Although today the ATAGI, the Australian guideline group for vaccines, is recommending that for severely immunocompromised people, they get a 4th vaccine dose, so a second booster, 3 months after the 3rd booster. And so we'll just see how the data evolves in that. So what does all this mean? It means that with Omicron, you're going to catch it out of hospital, not in hospital. Vaccines providing incredibly high level coverage against severe disease. The likelihood that anyone who's triple vaccinated is going to end up in ICU is incredibly small, and the likelihood that they're going to die is remote. We don't yet know how long the 3rd dose of a booster is going to last. It is inevitable, however, we're going to have more boosters, and I would imagine that we're going to have annual vaccines against COVID for at least the next decade. For yourself, get some paracetamol in for the headache and the sinus ache, and some Gastrolite for the diarrhea or vomiting that you might have. And COVID is not going to disappear anytime soon. It is a fact of our medical lives for the next 3 to 5 years at least, and possibly for the next 30 to 50 years. So we just have to get on and know how to adapt with it. And I'll pause there and take questions.
Thank you very much. That was fantastic talk. Okay.
Just trying to share my slides. Sorry.
Got a question on the chat. There's feedback for some reason. Sorry. If everyone could just mute their microphones, thanks. So on the chat, someone's asked, how do you respond to family members who question the long-term side effects of mRNA vaccines, which we haven't had the time to observe?
Well, mRNA vaccines have been in development for 20 years. If you think about how mRNA vaccines work, they don't get into the nucleus of your cell, okay? The mRNA gets into the cytoplasm and then makes viral protein in your cytoplasm, and that's then excreted. Traditional vaccines, like influenza vaccine, like AstraZeneca, like Novavax, are viruses. And what viruses do is get into your nucleus and co-opt your nucleus to make foreign proteins. And possibly half of our DNA is old viral junk. So if you're worried about mRNA vaccines modifying your genome and causing long-term effects, you've got to say the risk is higher with a normal vaccine approach than that. Ultimately, the proof will be in the pudding in 50 years' time. Can I guarantee you that we're not going to all turn into zombies in 20 years' time? Well, no, of course not. But you have to put it up against the risk of something really horrible happening to you with COVID. Now, if you're, and let's take average scenario of mum or dad here. Mum or dad's 60, let's say. A 60-year-old who's unvaccinated who catches COVID is facing about a 10% risk of being hospitalised, about a 2 to 3% chance of ending up in ICU, and about a 0.5 to 0.8% risk of dying. Assuming they survive, the chances that they'll have either brain injury, heart injury, or lung injury that will significantly reduce their quality of life is somewhere between 10 and 20%. So you've got to weigh up those odds against the theoretical risk that you might turn into a zombie in 20 years. I don't think it's a hard equation. I know that there's a lot of emotion around this, but you've got to reduce it back to, how there is no vaccines that have so far been shown to have long-term health risks. It is true that all vaccines carry a small risk. For example, polio vaccine, the original polio vaccine that was brought out, which was the live modified polio vaccine, in the 1960s, they realized that more cases of polio were being caused by the vaccine than by natural polio, so they switched to the heat-killed vaccine. With influenza every year, there's around a 1 in 50,000 chance of with an influenza vaccine of getting Guillain-Barré. It's a fact. There's around a 1 in 25,000 chance of getting idiopathic thrombocytopenia pura. These things happen, but you've got to put them into the context of what is your risk if you actually get the infection? And so is it a zero risk game? No. But, when you do the odds, if you're at the casino, there's no way you'd go with don't have a vaccine.
Thanks, Grant. I think I had a similar eye roll that you originally had when I asked that question every time I get asked that, which is most days, in fact, unfortunately. So we'll go to the next question and keep bringing the questions on. If we can't ask all the questions, I'm sure Grant will be able to answer them later on at a later date. But are there any particular patient factors that increase the likelihood of people progressing to viral pneumonitis versus endotheliitis versus cytokine storm?
Yeah, the data on who gets pinged out by what is not great. There's no question that pregnant women and people on high-dose steroids are more likely to get the early decline with the primary viral pneumonitis. That's something we also see, for example, with chickenpox, that pregnant women, there is something about pregnancy and it's relative immune suppression that causes that. We do know that if you've got diabetes, underlying heart disease, you're much more likely, those are the two big risk factors for developing the diffuse lung damage and needing mechanical ventilation. Interestingly, chronic lung diseases are not particularly a high risk. Now, there's a marginal increase in risk, but probably only what you'd expect, not a dramatic increase in risk like there is with diabetes and underlying ischemic heart disease.
Great, thanks a lot. I was going to ask as well, I noticed on the guidelines that you were talking about, they recommend inhaled budesonide as well. You didn't talk about that.
So inhaled budesonide is based on a single study in about 70 people. It was done by the primary author was an advanced trainee at Sir Charles Gardner in respiratory medicine, and he went to Oxford, and he's the first author on that paper. It must be said that no one's been able to duplicate that result, and that's not to say that it was fabricated. It's just, you know, sometimes you do a study and you get a significant p-value. Is it going to be harmful? No. Is there any evidence that it works? No. And interestingly, asthmatics, if anything, have a slightly higher risk of hospitalisation than the general community. So you kind of go, well, if it was having a dramatic effect, wouldn't you expect to see asthmatics actually vastly underrepresented? So look, it is not something that is part of the standard international guidelines, but people do adopt it based on that. But you've got to remember, it's one study of 70 people. It's not what I would call hard science.
Yeah, I was surprised to see it. So what is the evidence looking like around reinfections, Grant?
So there is some evidence from England and the Middle East that Omicron is significantly different enough from the wild type strain and Alpha that reinfections are common. Okay, so acquired immunity does not seem to be protecting against Omicron getting the infection, but the risk, but there's enough antibody in your blood with enough cross-reactivity that your risk of ICU or death is dramatically reduced. The other thing we've got to be aware of is that the body does not seem to be great at producing long-lasting antibodies to coronaviruses. So, you know, coronaviruses are a common cause of the common cold, and there's a lot of good epidemiological studies that show that people tend to get infected with the same coronavirus every 3 or 4 years. So it seems like natural immunity to coronaviruses is not well maintained. And so what I would say is, if you get Omicron and you're not particularly bothered by it, great, because that's going to bump up your relative immunity. And I guess our main worry is that there is another variant that comes through, which is actually more toxic. So, you know, in some ways, Omicron washing through the world is not a bad thing, because it will vaccinate effectively a lot of the third world that is currently not getting vaccines. And our major risk is that when we're not vaccinating the third world, that virus will continue to replicate and we'll get more mutations driven out of that. And until we're vaccinating the whole world, you can't shut down SARS-CoV-2. But there will be some acquired immunity, but it's probably not going to be long lasting.
Okay. And one myth buster that I wanted to ask you was antibody levels. Should we be measuring them?
Look, there's as a whole. So what Israel showed is that those who had 2 vaccines and got reinfected with Delta tended to have lower levels than those who didn't get infected, but there's no threshold cutoff. The other thing you have to remember is that antibody levels themselves are not the whole story. So elderly people tend to produce a reasonable amount of antibodies. The problem is that the avidity or the stickiness of those antibodies is not great. And what we do is when we're infected, you know, you produce 100 different antibodies and your body selects through and refines it down to a few that it believes are the stickiest. And then when you get reinfected or you get vaccinated, you refine it down further. So you don't actually need, it's not the large amounts of antibodies you need, it's actually good quality antibodies. And I think the value in, you know, going and testing and saying, oh, well, I need a booster now. The current recommendations are very conservative in that we're vaccinating quite early to cover for the people who are most losing antibodies. So I think just going with the guidelines is a much better approach at the moment.
Yeah, thanks. So there's a few questions about long COVID. So are there any risk factors that identify or predict the likelihood of long COVID, and are there any treatments to prevent it, for example, post-COVID brain fog?
So the more severe illness you have, the more likely you are to have long COVID, or at least the more likely you are to have identifiable pathology. with long COVID. And frankly, no, it's damage that you occur at the time of COVID. And until we get better treatments for COVID, there is nothing. Most studies in the past of critical illness have shown that in terms of recovery of neurological function and physical fitness, the two important things are exercise, or three important things are exercise, diet, and cognitive engagement. So, you know, if you want your body to recover, you've got to push it physically, feed it well. And if you want your brain to recover, you've got to feed it well and push it. So, you know, that's relatively simple. In terms of a lot of the psychological issues with COVID, the biggest predictors are a past history of depression or a family history of depression or alcoholism. And so, you know, that's a little bit around internal coping strategies and things like that.
Great, thanks. So this question around what should we be telling unvaccinated people? Should we be telling them that they need to be vaccinated to protect the community, or is it really, we've got such high vaccination rates now, should we be telling them to get vaccinated just for their own safety and reduce healthcare load?
So the studies that we have of people who are refusing to get vaccinated at the moment, I think indicate one of three things. Either they're someone who resents being told what to do. It's an anti-authoritarian stance. It's nothing to do with healthcare, with their health or their body or science. It's simply they don't like being told what to do. All that I think you can do with those people is kind of I try and appeal to the, well, you know, I'm not worried about you. It's, you know, do you have any contact with elderly people? Do you know, how old are your parents, your neighbours? How are you going to feel if, you know, one of them dies and they got it from you? In general, it's not a very effective approach because that group of people don't respond well to what they perceive as emotional blackmail. The second group of people have become addicted to some kind of pseudoscience on the web. And the problem with the internet is that, you know, if you believe that, I don't know, eating caterpillars is good for you, you can find a web group somewhere that tells you that you're completely normal, and you can hang out with people who do nothing but eat caterpillars. And all you can do then again is try and acknowledge where they're coming from and gently over time try and educate them and provide them with advice. Again, this group of people just tend to be very difficult to convince because they will read their skewed version of science and not believe what we believe. And again, appealing to their social conscience is about all we can do. They, in general, don't believe the risks themselves. And then finally, there's just a group of people who haven't been bothered or poorly educated. And those are the ones that we really need to get to and encourage to get vaccinated.
Yeah, agreed. Look, we're running out of time, so I'm just going to ask a few more questions if I can. So one question that got quite a few likes is there any point in wearing cloth masks?
So a cloth mask is better than nothing. In general, it's around the fit of the mask. A cloth mask is probably as good as a surgical mask, but once it gets dirty, all masks, once they get a bit wet, they don't stop virus transmission very much. So a surgical mask is better for you than a cloth mask. An N95, provided it's been fitted, is better again. But an unfitted N95 mask is just the same as a surgical mask.
Okay, I might I've got one more question myself, but I might give the other questions and send them to you, Grant, and see if you can answer them quickly, and we can circulate it on LMS if that's okay. But I wanted to ask the question I wanted to ask, which I actually want the answer to, is you would have seen the modelling now, the revised modelling. How long before we get to the other end of this? You know, when will the students be able to get a semi-normal kind of clinical attachment experience, do you think?
Look, the truth is, I don't think that the peak will be until late March, early April. I think if we look at data everywhere else, that peak will last 4 to 6 weeks, and then there will be a slower. It's a peak and then a slower decline. I think that the hospitals will be under the pump until at least mid-July, and then we'll be running into winter. And the big risk at the moment is actually not Omicron, it's that influenza will arrive. Now, when influenza arrives, it will be the worst influenza season we've ever had, because hospitalisations and deaths from influenza depend on, the biggest predictor is the number of cases you've had in your community for the last 2 years, because vaccine doesn't actually give you much lasting immunity. Vaccine for influenza lasts 6 to 9 months in terms of peak immunity, and its effectiveness, we're having all these media debates over Pfizer versus AstraZeneca, and 92% versus 88%. Well, I want Pfizer. At best, influenza gives about a 45%. Influenza vaccine gives about a 45% reduction in hospitalisation. So influenza is what we're really worried about. When will they get a normal experience? This year, COVID's going to completely detrain the beginning of the year. There's no question about that. I cannot see us getting back to normal before July. And probably a bit later after that. That's the reality. So what we need to do is figure out how we continue to try and provide the best experience we can. And the big issue is actually not patient load; it's staff illness. And we're at peak. We're probably going to be having 20% of our staff not available due to either being sick with COVID or having to be at home caring for someone, a child or a family member with COVID. For 4 to 6 weeks, and that's going to completely cripple our health system, and that's going to be tough. Yeah, thanks.
So really need to take the opportunities when you can this year for future. Look, Grant, thank you very much. The key things I wrote down were 70 to 80% of us are going to get COVID. Reassuring data on triple vaccination, and all final years have been triple vaccinated. I'm glad to report. I don't know the data for the other years, and the last thing I wanted to add was PPE, super important, and correct use of it. So, Grant, thank you very much. Fantastic talk. I'll send you some other questions later on that you can answer in your leisure, and I'll publish it on LMS. But thanks a lot. Thank you to everyone for joining us.
Thanks, Neil. Thanks, everybody.
See you, Grant. Thanks.